My name is Seidu Bello, and I will be your presenter. I'm going to give you a little tip, which just the bone. Then I will expect everybody in the house to add flesh. So thank you very much for having me. Um, atypical facial cleft is the topic for today. And for the next 30 minutes, let us see how much information we can share with ourselves. First of all, we are going to follow this brief outline, which we are going to follow this brief outline for this presentation. I bring greetings from my center in Abuja, the Cleft and Facial Deformity Foundation, which, as I said, which also double as an International Craniofacial Academy, where we try to encourage or we are trying to develop training skills for Nigerians, for CMF specialists and students. So, first of all, for this presentation, I will want to bring my special appreciation to two gentlemen, Charles Wang and Ibrahim Mulani, who jointly formed Smile Train in 1999 in the United States of America. They came up with a unique concept. I call it unique because hitherto, what has been the practice is the Western world to send practitioners to developing world to assist them for surgical repair and assistance. But now, this gentleman gave it a thought and said, why do we continue to send professionals? Why don't we try and see how to develop manpower in these areas? And I want to tell you, it is this thought that has brought all of us. Now, the whole of Africa, the whole of Middle East, the whole world now, cleft management has become something very common, courtesy of these thoughts. It's a very unique one. And for all these activities, I also want to specially thank our NKOB, which I believe is an household name, who is the program director for West and Central Africa of Smile Train. She has been doing so much for us to have this, at least Nigeria that we are, we can see the example. Now, this is a very beautiful collaboration between West African College of Surgeons and Smile Train. And that is why I want to inform my teachers that I'm also a proud fellow of West African College of Surgeons. So this is a beautiful collaboration between Smile Train and I'm very sure all of us have been happy, we have been benefiting, we have been learning from what is being done from different parts of the world, from Ghana, from Kano, from which is a whole lot. Is awesome. So thank you very much. Please keep it up. Now, for this presentation, I want to declare no conflict of interest. This is a pure academic exercise. And I also want to disclose that I have permission of my patients to use the pictures for educational activities. So permit me, no issues when you be seeing the pictures. I can only talk with these pictures, which we've operated over the years. The learning objectives for this presentation is I want the audience to be able to appreciate the concept of atypical facial cleft, to be conversant with the presentation and nomenclature of classification of atypical facial cleft, and to appreciate the principle of management of atypical facial cleft. Now, the topic of today, as has been said, is atypical, which is also called rare facial cleft. And the real focus is going to be our paper, which we have published about a study of 36 cases by Cleft and Facial Deformity Foundation, Abuja. By the way, Cleft and Facial Deformity Foundation is an indigenous surgical mission that was established by my humble self with a lot of practitioners from Nigeria, volunteers, and we have been operating since 2011. We are concentrated in North Central, even though we have made some little incursion to places like my Oyo State. So what we've been doing since 2011 essentially has been rotatory outreach programs. We've been to different places, and I think among practitioners now, I think our name is a little common. We have been doing, and we must have covered not less than 10 to 12 states in the north central. Nigeria is a big place. So I must say that out of 36 states, I'm sure we must have covered up to 10 states. And now we are also proud to say in the past 2 years, we now have a surgical center in Abuja where we are not doing outreach programs, we can still operate continuously, even though we are developing the center. Now, this paper was published in the Cleft Official Journal, which is an American journal, in 2018. And it is a typical facial cleft from North Central Nigeria, review of 36 cases. And this case was published, and this paper is going to be the focus of our presentation, which essentially is our experience. Now, the aim of the study was to present the pattern of presentation and treatment of atypical facial clefts. And yes, as a way of introduction, yes, I'm sure we are now getting to our familiar terrain where we now stop talking just theory. Smile train, why Smile train is actually unique. I'll keep on sounding this is because myself, before I became a consultant, I am not sure if I've seen cumulatively up to 20 facial clefts. But even a 400 level medical student, dental student now can claim to have seen up to 50 before he or she even graduates, because it is now everywhere and there is access, because somebody is providing the fund and supporting training and all the activities. Now we are moving to comprehensive cleft. We can see this is a left unilateral cleft lip. This is a bilateral cleft lip, and this is an isolated cleft palate. This is another isolated cleft palate, if we go secondary. And this is a case of a bilateral adult cleft, bilateral cleft lip, and this is another right unilateral cleft lip. All these ones, which we are all very familiar with, is referred to as typical facial clefts. So if somebody has cleft lip and palate, it's typical facial cleft. But for those of us on the field, we realize that sometimes this cleft does not go typical. We want to have involvement of other parts of the face. And that brings us to the topic of today. And what are we seeing? This is it. This facial cleft can affect any part of the face. I'm sure we can appreciate this young lady, this young girl. We can see affectation of the divided lip, the nose. This is tertia O. We'll come to the nomenclature later. This is another one. We can see this is not cleft lip, it's not cleft palate. This is atypical or rare facial cleft. We can see cleft even involving the nose. So this is this, and you can see this begging boy that was brought from Kaduna by some good Samaritan. This tertia 3-4, which is also oblique cleft. We can see also affecting part of the face. These are called these are atypical facial clefts. And what about this young boy involving the lower lip? This is actually called tertia 30. We are coming to nomenclature, as I said, but this is not cleft lip and palate, which are typical, as I said. Cleft lip and palate is when they are typical, but they are not. And we can see this another tertia O, which is a small boy with a cleft on the lip. So without too much words, I'm sure all of us in the house can understand what I'm talking about, what my flow, difference between typical and atypical facial cleft. So we've had so much. Everybody has been talking about facial typical cleft. Now I want to add a little about our knowledge about atypical. And for the next 30 minutes, if you permit me, this is what we'll be talking about. Now, for the purpose of communication among practitioners, nomenclature is something that we are all familiar with. Because you should be able to communicate. Yeboah is in Ghana. If I see a case now and I say, yes, I've just seen a case of tertiary O, you instantly understand what I'm talking about. So that's the essence of nomenclature. So there have been a lot of classification. There have been a lot of classifications of atypical facial cleft. I'm sure if I ask us now, if I ask us to classify, okay, we'll come to that. Now, classification. There have been several classifications in the past: Cafe, Bochia, Dimea, Mullen. All these who have tried to classify atypical facial cleft by virtue of their understanding. They publish their different papers. But what happened with Portesia is a kind of is what I would say is an innovation that that has come to stay. Portesia in 1976 had his presentation, and Portesia's presentation in 1976 was the most acceptable, and because of the anatomical presentation and its ease of explanation to practitioners, so it makes communication easy. So what is the tertiary classification? Tertiary classification look at the face as a spherical object.
Dr. Bello?
And, yes, sir?
Please hold on a little bit.
Okay.
It looks like people are complaining of the voice. They said they can't hear you well, the voice is not good. But for me, I can hear you clearly. I don't know what is happening to their, I don't know whether it's their private internet or is, because I can hear you clearly. So I don't know if you can do something about your volume, your voice volume, so that it can be a bit higher.
I really don't think so. From what I have here, if you are hearing me well, too, I don't think I don't have anything to do. I don't have anything that I can do here.
All right. So I think maybe they have to do something to the. Okay, someone said he can hear clearly too. So I think that is okay.
Okay.
I also want to use this opportunity to remind you or to put your questions on the chat room. Thank you very much. So please continue.
All right. Thank you. So Portesia in 1976 is the most acceptable. Portesia assumed the face to be a spherical object, and this interpupillary line was drawn that passes through the two eyes. This interpupillary line is actually tertiary 8. Eventually, we will get to understand that. Now, everything below the eye is referred to craniofacial clefts, and they are named from the center after 0, after O is named to up to 7. So from the midline, you continue to go laterally. From midline, you continue to go from midline here. Midline is tertiary O, and you now continue to go laterally, tertiary 1, 2, 3, up to 7. Then, as I said, interpupillary is tertiary 8. Then from tertiary 8, you go again from lateral, tertiary 9, 10, 11, 12, 13, 14, 15, 14. So I take that again. From the interpupillary line is the equator that defines the spherical object. Below it, you have craniofacial. Below it, we have craniofacial cleft, and the midline is tertiary O. Then from tertiary O, is 1, 2, 3, 4, up to 7. Then tertiary 8 is the horizontal. Then we start from the lateral again, 9, 10, 11, 12, up to 14. Cleft of the lower lip, especially called tertiary 30. So basically, this is what we have. It now means that then above, that's what I said. Above is tertiary 9 to 14, starting from lateral. So basically, this is what you have. It now means that tertiary O below at the craniofacial clefts continues as tertiary 14 above the orbit. So basically, that is it about tertiary. Now, we will actually appreciate this more as we go along when we look at development of the face. So in summary, we have the orbit as the equator, which is tertiary 8. Then everything below it is craniofacial cleft and the tertiary 0 to 7. And above it is the cerebrocranial cleft, which is tertiary 9 to 14. So that is nomenclature introduced by Paul Tessier. And it is most acceptable because it's very easy to explain. Now, for us to actually appreciate Tessier classification, it is important we remind ourselves of the development of the face. You know, during the 6th to 10th week of pregnancy, the bones and the soft tissue, mesenchymal tissues of the face develops. And as we all remember, this is the frontonasal process, which has the nasal swellings, and this is the stomodium, which is the margin mouth, and of course, this is the mandibular process. The mandibular and this maxillary process, the maxillary and the mandibular actually constitute the first pharyngeal arch. This is just to remind us, and this is the arch here. And what all these develop into, we'll appreciate shortly. Even though I know very well that we are talking to professionals, most people actually already know what I'm talking about. But this is the frontonasal process, which is the developing brain. Now, we now have the frontonasal process. This is what we have to appreciate. This is the developing nose. And this yellow, in yellow we have the medial nasal, we have medial swelling. We have laterally, the blue represents the lateral nasal swelling. What simply happened in the course of development, of course, this is the stomodium, this is the cardiac bulge, and of course, this is the maxillary process in pink. The mandibular process is a little below, it's not shown here. Now, what could simply happen is that this yellow, which are the two medial nasal swelling, merge at the center to form the middle portion, forms the middle portion of the nose, forms the middle portion of the nose, forms the middle portion of the upper lip, and forms the middle portion of the maxilla. Actually, it forms the primary, the four incisors and the primary palate. Then the lateral, this is a common student mistake. The lateral nasal swelling does not form part of the lip. This blue lateral nasal swelling eventually just forms the ala of the nose and it does not participate. So the medial nasal swelling and the maxillary process fuse together to form the upper lip. Now, defects in these lines will actually bring about clefts. So let us see what we have in face. So eventually, this is the summary. The middle portion, the medial nasal swelling, eventually form the middle portion of the nose, the filtrum, the primary palate. And the two halves of the maxillary swelling join the central portion to form the upper lip. And the mandible, the two processes fuse together to form the mandible and the lower lip. Now, when it comes to the palate, what simply happens is that we need to have two palatal shelves. This is just a reminder. The two palatal shelves, right and left, mix at the center and meet the primary palate anteriorly, and also the nasal septum. Eventually, this will form the palate. Now, let's look at a few examples so that from there, we will be able to appreciate, first of all, the typical before we now go to the atypical facial cleft. This is the young man from Bauchi that I saw some years ago. We can see, we all agree, there's no doubt that this is left complete unilateral cleft lip. Then what happened? What happened? What simply happened is the fact that on this left, the medial nasal swelling has formed normally, but the medial nasal swelling here and the pink, which is maxillary process, fail to fuse. And that's why we have left unilateral cleft lip. The medial nasal swelling, as I said earlier, just to remind us, and the common student mistake, the lateral nasal swelling, which is blue, does not participate in the lip formation. It actually forms that's why this man's nose is still complete. The lateral nasal swelling is there intact. But the medial nasal swelling as well as maxillary process on the left fail to fuse. And that's why you have left unilateral cleft lip. The same thing, we can see this girl. We can see this girl also has left unilateral cleft lip, which is the same medial nasal swelling as well as maxillary process fail to fuse. And in the course of repair, this is what we try to do. We try to bring it together so as to form near normal lip. Now, this is a right unilateral cleft lip. We are still on typical. The same way, we have the medial nasal swelling here. The yellow are fused to form the bed. This blue, which is the blue, has formed the alar. This girl still has the alar here, but the maxillary process here, which is the pink, failed to fuse with the medial nasal swelling, and that's why we have right unilateral cleft lip. Now, when it comes to cleft palate, as we said, the palatal shafts, right and left, they fuse together. Now, the failure of these, you see, the palatal shafts, the two fail together to meet at the center, and that's why we have this cleft palate. Incidentally, in this case, it's isolated. The primary palate is intact. So the problem is mainly between the two palatal shafts to form. Yes, and the fact the same palate, this is the same thing. This is actually bilateral cleft lip and palate. In which case, we have the palatal shafts, they fail to fuse, and we also have the failure to fuse the primary palate. And of course, in the course of repair, this is what we try to do, bring the mucosa together to form a complete palate. Now, in bilateral cleft lip, what happened? What simply happened is that we can see the prolabium here standing. That is also depicts clearly what medial nasal swelling actually results to form. And we can see the alar of the nose well formed here, because that's the blue, that's the lateral nasal swelling. But when these form, they fail, the pink, which is maxillary process on the two sides, they fail to join bilaterally. And that's why we have a bilateral cleft lip. And so this is how it presents. Now, enough of the typical facial clefts. Now let's go to other clefts of the face, which is the atypical now. What really happened? Now this is a tertiary O, in which we can have failure, even though incomplete. We still have a fusion, but incomplete fusion. So we can see this, and of course we can see this other one in which there is total diffusion of the upper lip as well as the nose. Now, in that wise, what happened is that the right and left medial nasal swellings, they fail to fuse. And the failure of fusion of the right and left nasal swelling, medial swellings, is the cause of cleft in tertiary O. Now, what happened in tertiary 1? In tertiary 1, it means that the medial nasal swelling was well formed, and the whole lip, the pectorum, the lip was properly formed. But what happened? The lateral nasal swelling, which is supposed to form the alar, that's a failure of fusion. So the failure of fusion between the lateral nasal swelling and medial nasal swelling brings about tertiary 1. And that is what we can see here. So this is a tertiary 1 on the right and on the left. Now, this is a tertiary 2, 3, 4. I must sound a note of warning. Some of these may actually be difficult to explain, but it's still also, at least we can see a clear line. Like in this case now, we can see, as we said earlier, a line passes through the pupil, the equator, from 0 to 7 on the tertiary 0 to 7 from craniofacial cleft. So in this case, we can see an attempted the medial nasal swelling. Yes, the right lateral nasal swelling and medial nasal swelling, there's no sign that they fuse properly. And the right maxillary process totally is detached and from the nasal swelling. as I said, the explanation may not be too clear in complex cases, but basically that's what we are seeing. We can see the whole of this maxillary nasal swelling is just the maxillary process is totally detached, and that's why we have the medial nasal swelling, the yellow fused together, but fusion to this other element became the issue here. And tertiary 4-5, just like I said, in this case now, this is also called oblique facial cleft. The maxillary process, the maxillary process actually fuse with lateral nasal swelling. Lateral nasal swelling and maxillary process diffuse. There's failure of fusion, and that brings about. This is an incomplete case. We will continue to see how some of these things will affect. Of course, you can see this chromium primarily. You can see this agenesis of this right ear. These are syndromic cases, and we can see this in many of these presentations. Tertiary 7, we can see it also called lateral cleft. Clearly, we can see this is the mandibular process here, and this maxillary process. The mandibular process and maxillary process, there's failure. So I hope you can appreciate this line. It is this line that's failure between this maxillary process and this is the maxillary process, this is the mandibular process. Failure between the two is what brings about tertiary 7. And this same thing we are seeing here. So that is how we can have tertiary 7. Yeah, this is a popular man I call allergy. What really happened is that we can see tertiary 8 has to do with this interpupillary line. And that's what we can see here. We can see this defect laterally, and that is tertiary 8, in which case we can see is a failure between the frontonasal process. You know, frontonasal process forms the whole of the mid portion and the brain. Between frontonasal process and maxillary process, you see this is maxillary process, and this is the frontonasal process. It's the failure between the two, the failure of fusion between the two is what brings about tertiary 8. Now, tertiary 30. Yes, we said mandibular process. Mandibular process, right and left half of the mandibular process fuse together at the center to form a complete mandible. Now, a situation where they fail to fuse, we can see this tertiary 30, and we can also see tertiary 30 on this side, this same thing. So we have the lower. As I said earlier, this is how tertiary described. We have tertiary 30. Now, as I said earlier, yes, we can see clearly this bilateral tertiary 1, which is a failure of fusion between the medial nasal swelling and lateral nasal swelling. As I said earlier, the lateral nasal swelling forms the alar. So the mid portion was formed by medial nasal swelling. So the failure between these forms the bilateral tertiary 1. But the thing is that we can see that beyond the pupil, there's still an extension of this distortion. When we actually have the CT scan of this patient, and it also shows bony involvement. That's what happened in this tertiary cleft. We can also have bony involvement apart from the soft tissue. And we can say, as I said, tertiary 0 continues superiorly as tertiary 14. And so if we are going to describe anything, we can here is just be described as tertiary 14. Now, this is difficult to explain. It's a complex. It's sometimes part of syndromic cases. It's actually called lateral proboscis. You can see some people say it's a hanging nose. In those days, during Baba Salah time, you see, you show something like this that it shows like a hanging nose. I think this is similar to what we're having here. As I said, it's difficult to explain from embryonal diffusion defects. But these are tertiary that we see on the field. So in summary, like I said earlier, some of these ones I've explained from the orbit, which forms tertiary 8. Below is the craniofacial, cleft from 0 midline down to 7 on the left. And from left again, tertiary 9 starts and comes to midline to be tertiary 14. So tertiary 0 below continues until superiorly as tertiary 14. Now, when we have this tertiary 14. When you check the literatures, there are other modifications that are also in the literature for easy explanation among practitioners. For instance, we have median clefts. I've shown a number of tertiary O, tertiary 1, tertiary 2 may not be common. So these ones from 0 to 3 is called median clefts, middle or median cleft. And tertiary 4 to 6 is referred to as the oblique cleft, whereas tertiary 7 is referred to as lateral cleft, like we can see in this case now. This lateral cleft. This is 4 to 6 is the oblique cleft, middle cleft. These are used in the literature. Also, we can also have modification. We can have unilateral. You can have unilateral tertiary 1. You can have bilateral tertiary 1. So it could be either unilateral, it could be bilateral. These are in the literature for explanation. Also, these are also tertiary 7. Tertiary 7 here could be unilateral in one case, or could be bilateral, as we had in this little girl. Also, tertiary cleft could also be associated with the normal typical cleft, as you can see in this girl. Now, complex, all these facial clefts, many of them are actually complex, and there are a lot of bony involvements. And when you take a CT scan, you are going to see like this particular little girl. When we took this CT, the CT report was amazing. Almost all the bones of the maxilla were actually deformed in one way or the other. There's hypoplasia, the sphenoid, the tempora, almost all the bones, and we can see the big defect. That should be expected in the cleft cases. Cleft could also be associated with syndromes. Like in this case now, this is a case of probably trichacholin, or somebody would say mandibular arch syndrome. You can see it's actually second arch syndrome. It involves not only the lateral cleft. You can see the hypoplasia of the formation of the right ear, and also right hypoplasia of the mandible. This is possible. This is also a case of tertiary 1 that's also associated with this is actually called Ritter syndrome, when there is ocular involvement. So you can have all these associated with part of presentation. Now, earlier studies, even in Nigeria, have presented several cases of atypical facial cleft, but the largest, I'm not too sure, I'm sorry, in the past 1 year, there might have been others, but the one that I could lay my hand is Adeosun et al., Adeosun and Oga, that presented 9 cases of atypical facial cleft. We also have several presenting 1 case, like my friend James and a host of others in Nigeria have presented several cases of maybe 1 case study. So now, based on that, the justification for this study is to, 1, document our experience, which we saw in the field, and also contribute a relatively larger number than what is being reported, number of cases of atypical cases, so as to broaden the knowledge, increase to the body of knowledge in the subject of orofacial cleft. The methodology, CFDF actually offers free surgery in the North Central in Nigeria from 2011 to date. And this is actually part of a larger study. We have been publishing others, part of a larger study on orofacial cleft. All the cases of atypical facial cleft were included in the study. Demographic data, pattern of presentation, the surgical detail, and outcome were documented. And the clefts were classified using a modified Paul test here. The data was analyzed with statistical package for social sciences, version 20. Method of repair, excision plus direct closure, advancement flap. Then we also have some complex soft tissue reconstruction. The treatment was broadly classified into this. Now, let's see a few examples, like this tertiary 7. Yes, as I said. One thing about repair, surgical repair of atypical facial cleft. I'm sure if I open the floor now, tell me about the repair of cleft lip, I'm sure there will be flowing. Malar rotational advancement flap, tennis randa, lemesuria, straight line, all sorts. If I ask for cleft palate, I'm sure the floor will be full. Lagenberg, Walker, or Clean, Bada, Follow, and all sorts. But if I ask for atypical facial cleft, the logarithm has been difficult by practitioners. The essential thing is that the repair in the atypical facial cleft is anatomical. It's anatomical. We repair the way we see, based in mind the knowledge of anatomy. So, like this tertiary 7, all we did was de-epithelialization, excision. Then after excision of the epithelial surfaces, now we have to do direct closure in layers. Mucosa, or first of all, for tertiary 7, it's very important to use the commissure on the contralateral side as a guide. But in a situation where it's bilateral, then you have to use your judgment. Now, like this one, there was no trouble with us. We had the normal on the left, so we use as a guide. And after that, after our excision, we close in layers: mucosa, muscle, and the skin, and it came out to be normal. This is also a case, not classical lateral cleft per se, part of syndromic, as I said. But of course, this is the major thing that was a problem to the parents. We are also able to anatomically oppose the pinna, and we are able to get a result there. Now, when it comes to oblique cleft, it is important, like this tertiary 4-5 oblique cleft. It is important to have a wide exposure. When you have a wide exposure, then you'll now be able to close anatomically. Sometimes it may be necessary to introduce some C-plasty to break and improve cosmesis. So this is what was done in this case by wide dissection and transposition flap. And we're able to get something that is a lot better than how the patient came. Cases like this, definitely you may have to do many step surgery in some of them. Now, this is a case of lateral proboscis, as I said earlier. Yes, very typical. And yes, we also did the wide dissection too. And we are able to come up with something that is in the semblance. Definitely, this cannot be a one-stage surgery. But unfortunately, our society is so funny. The mama who is a step mother, there was no true knowledge of what happened to the mother. But it disappeared, and we call her to come back. We will not see her. But basically, this is the soft tissue reconstruction. Then this is another case of a lateral tertiary 7, which is a lateral cleft, also in the tertiary patient. But you see, Potentia himself emphasized the issue of soft tissue reconstruction. Even when there might be a question, yes, what happens when you have bony, even when there's bony involvement, soft tissue reconstruction, and even cosmesis is very important. That's what actually will bring somebody to see a specialist. Now, this is a case of nasal defect. Yeah, somebody can take me up. Are you sure this is anyway? Whichever way, we did all we could from the parents, but they insisted this is how the parent was born. So we have to settle for tertiary 1, 2, 3. Anyway, the most important is that we had a repair, and we were able to use a superior base nasolabial fold bilaterally, and it had something that I think the parents were happier. Now, this is also a case of bilateral tertiary 7. Also, we were also able to do the same thing, the epithelialize and suture layers, mucosa, muscle, and skin. And a smiling girl actually greeted us 2 months later. This is another case. Somebody may also take me up that this is distorted. Yes, we also did all we could. The parent insisted it was not born, and that's why it was born. Anyway, we believe the most important is that it's a tertiary O, and with soft tissue reconstruction, we are also able to excise and get the layers, and we're able to get a straight line repair of the lip. Yes, this is a case I saw in Jalingo. Also, we can see the tertiary O, how it has divided the lip and the nose, and we're able to have a wide excision at the center, a wide excision, and that brought this a kissable lip, I would say, and a nose that is, I want to say, is near normal, if it's not normal. Now, this is tertiary 30, the same thing. All we need to do is a wide excision, and you may have to excise some tissue and bring together mucosa, muzzle, and we close the skin. This is a case of tertiary 14, which, as I said, we can see very obvious hypertelorism here. And as I said, CT scan also shows that the bony underlying bone also had defects. You see, what is important to this patient is to be able to see if there should be improved cosmesis. And this is what we did. You can see with this wide excision, you can take off this excision, we're able to do some soft tissue reconstruction and reduce the hypertelorism. As I said, this kind of case will definitely require more than one surgery. Now, the result shows that we had 36 patients. We had the age to be 11, the range was 1 to 34. Our male to female ratio is just 1 to 1. There were 586 typical clefts at the same time. It means that we are able to ratio 16 to 1. And if you take it to 1,000, we have 61 per 1,000. If you use a rubellum, which has been our reference, it comes to 1 to 40,750 live births. The cleft types, cleft 1 was actually the commonest, type 1 was the commonest, followed closely with tertiary 3 and 7, whereas tertiary 6 was the most uncommon. Then, associated conditions, we have agenesis of the eye from forehead bursting, called different microthermia, but it's instructive to say that in 69% of the cases, there was nothing associated, which means that they could undergo simple surgery. On the sidedness, we found out that there was nothing significant. In the median, the right, the left, could be right, left, the median is not really significant. And the pattern, the middle cleft is about 60%, oblique about 24, lateral 15. We can see this oblique that's up to 24. Then on the type of surgery, excision direct closure was carried out in 66% of cases, which means that majority of these cases could actually be managed with simple. What's the outcome? We're able to follow these patients from 2 months to 4 months. On the Likert scale of 1 to 5, 90% actually are strongly satisfied that there have been serious improvement. 5.6 appear that agree that they're somewhat satisfactory. The complications recorded were mild wound dehiscence, which were treated with mild local treatment. In the literature, the incidence of about 9.5 to 34 per 1,000 have actually been recorded. So we believe that, yes?
Yes, if you can conclude in probably the next 2 minutes so that we can
I am. In 3 minutes, I'm looking at time. So yeah. 61 in 1,000, it means that what we are actually having is actually higher. 61 to per 1,000 is actually higher than what has been reported. In terms of sex, is not really significant. Age, adult cleft is still our problem, which is in our case. And in terms of pattern, it's actually not too different from what has been reported. But Tessia has reduced confusion. The algorithm for surgical management is anatomical, with optimum use of direct closure and loco-regional flaps. In case of cerebrocranial, complex imaging will be needed. But the treatment is individualized in all cases of atypical cleft. The take-home message: atypical facial clefts may not be as rare as it is often described. It presents in different forms, but tertiary classification has reduced crisis of terminologies. Earlier I said with it. And surgical management is anatomical and is individualized. Once again, I want to thank Smile Train and West African College of Surgeons for this opportunity, and my audience and my moderator. Thank you very much. Thank you.
Thank you very much, Dr. Bello, for such a wonderful presentation on atypical facial cleft. Thank you for the nice explanations into the Tessier classification, and also well done for the good work you are doing at your center. We now want to look at some few questions that people have brought in the next 10 minutes so that we can leave here. Right, so the first question to you is that with the Tessier cleft classification numbering 0 to 3, 0 to 14 and 30, what if one finds another atypical rare cleft outside this classification? Will you call it a modification or just add the number on, continue to add numbers? The second question you added to because they are related. They said, thank you for the lecture. It said that unilateral clefts are more common on the left. Why is it that atypical facial clefts are more on the right? Any reason? And if you have done any research to show that too, you can let us know. So if you can take these two questions, then we come back.
Thank you very much. That's actually a very interesting question. I want to let us know that what I find very interesting about science is that it continues forever. Like like this distinguished surgeon rightly observed, if based on your own observation, if you see other things and you feel you need to add, you can all you need to do is to publish it. If you're able to find something that you think are consistent and is outside Tessia, it's a very simple thing. All you need to do, if I have done that, probably you will have seen it before this question, you will have seen the result. Because if I will be too happy to see some that Tessia has not described, and I will say this is Bello's modification of Tessia. So I can even call independently Bello's classification of atypical facial cleft. So it's not a problem at all. We are still expecting anything can still happen. As a matter of fact, that after Tessia, there is one Indian author that presented something. But for me, it was far more complicated and it's difficult to explain, and that's why I just abandoned it. Yes, the issue of laterality. If you remember, in the course of my presentation, I don't know if I'm still sharing this slide. Yeboah, am I still sharing it?
Yes, you are still sharing.
Okay, now if you look at this slide now, this is actually the scientific finding recorded and published. In terms of sidedness, because it's deliberate, because just like you rightly said, cleft lip is commoner on the left. But this is what we find out. The median cleft about 33%, right about 25%, left 22%. So bilateral 16%. Really, we don't really have the issue of sidedness, whether right or left, is statistically insignificant. So to that extent, we will just say that for atypical facial cleft, we don't have it commoner on right or left.
Okay.
I hope that answers that.
Sure.
Yeah.
Thank you very much. The next 3 batch of questions, let me take 3 questions. We have about 8 more. So the next 3 batch of questions is that, is there a clear distinction between Tessier 4 and 5? And then the next question is there algorithmal indication for clefts respect to cleft repair, atypical cleft lip repair? And then secondly, does mitrain support all forms of Tessier? And I think for that question, NK has brought an answer, so I'll talk about that one. So you can take that one, and then let me add the last one to it.
I feel highly honored for this question. of difference between tertiary 4 and 5, because it means that the person that asked is already a professor of atypical facial cleft. My answer is that there's no difference. But for me, please don't say I'm an authority. I could not find a difference, and I've also asked myself several times, but I could not find a difference. So if you see my presentation, I showed the case of tertiary 4-5, which is an oblique cleft. So it stops there. I couldn't find a difference myself. That's the truth. Then a logarithm, I've explained this. When it comes to, you don't have a logarithm. A logarithm I've tried to present, but it's difficult. For tertiary cleft is anatomical. However, it presents to you with your knowledge of anatomy is how you repair it. We have some complex cases. For instance, duplication of the whole face. We've had, it's also a form of, we have duplication of the whole face, duplication of the whole maxilla, of the whole mandible. All these have been presented. For those ones, yes, some people can come out with a logarithm for individual cases like that. But to talk about general logarithm for repair is simply anatomical. Excise, do its deepithelialization and close in layers. The mucosa, the muscle, and the skin. Thank you.
Okay. All right. So yes, the other questions. Thank you very much. Yeah. So okay. So then let me just add from what NK said. NK says that Smile Train finds the following 7 types of cleft lip and palate surgeries: primary lip nose unilateral repair, primary lip nose bilateral repair, primary cleft palate repair, fistula repair, secondary cleft palate repair, and lip and nose revision and alveolar bone graft. So these are what is on Smile Train sponsorship program. Maybe as time goes on, they will add the craniofacial aspect to it. We will look at that. Okay, yes. So
yes, sorry, Dr. Ebo, if I may add to that, probably because of the rare nature and maybe many people have not been putting them forward. Now, Smile Train, we want to implore them to look at this because they are clefts, and people those that have the problem will always come along with the cleft lip and palate too. But probably because of the rare nature, that is why it has not been captured.
Okay. All right. So the next questions say, thank you for your presentation. For middle atypical cleft 0, 14, and 30, what other midline defects of the brain, heart, or spine did you pick on your examination and investigation? Second question is, when do you operate on the bone defects? And concerning the bone defects, there are about 5 questions asking about what about the bone, what about the bony defects. So you put all that into that bony defects repair. And then the third question is, please, how do you take care? I mean, it's also bone, so take care of that one.
Yes. Yes. Thank you very much. The simple thing is that if you see my presentation from beginning to the end, I didn't present a single case I didn't present a single case with bone management. I've never attempted the issue of bone but I said something. I said in a number of these cases, when you take CT scan, there are bony involvement, and it now becomes a complex surgery that will be multidisciplinary, involving neurosurgeons. But what I've done, which I've presented and will also publish, is essentially the soft tissue management. But it's important to note that yes, in complex cases, I said it in my presentation. I said when you have cases that are ranging from the outside these simple cases, now you have to, of course, the CT scan will be needed, and with the CT scan, whatever defect you now discover, it will now require multidisciplinary approach, especially neurosurgeons, probably depending craniofacial surgeons, and plastic surgeons, maxillofacial surgeons, depending on your center. That is beyond my capability for now, and I didn't attempt that. But one thing I've been able to establish from the cases that I presented is that at least more than 60% of these cases are simple, and you can make people happy by attempting to them instead of just assuming we maybe just send them away. I hope that answers the question.
Yes. Okay. So I think that follows up with the next question, which probably you have answered it halfway. It said, as regard the nomenclature of classification, the use of the term cerebrospinal be substituted by cerebrofacial.
Yes.
And secondly, what other specialties are needed on the team in the management of Tessier cleft? Okay. The next one says that, are there any known cleftogen associated with atypical cleft facial cleft? Atypical facial cleft. Are there any known cleftogens?
Cleftogen.
Yes.
Okay. Okay.
Associated with atypical facial cleft. And then the last question says that, I would like to know if the nomenclature of classification of cerebrospinal Tessier be substituted like the same. So
sorry, that the person would like to know if it was.
If the nomenclature cerebrospinal Tessier can be substituted with cerebrofacial.
You see, okay, all right. Thank you very much. As I said, science is evolving. There is no limit to what, and you know, whatever I've written down, somebody will read my paper and quote it. What others have written is what we are quoting. I've never seen Tessier in my life, but I'm quoting his work based on what I read, what is available in the literature. The simple thing is that yes, he used the terminology craniofacial cerebrofacial was used, but whether it could be substituted, yes and no. The question is, substituting it is not a problem. All you need to do, if you have your own paper and you feel it could be substituted, explain it. Explain why it should be substituted. And if you explain it, and yes, reviewers look at it, and that's why papers will go peer review. When if other specialists agree with you, then we begin to quote you. For instance, if my friend Yeboah now has his own paper and uses this other terminology, that is how things are done in science. Not really for me to say yes or no. Whether I say yes or no is immaterial. But what is important is that if I feel it could be substituted, and I present a paper, and I'm able to, this paper undergoes peer review and is accepted. That means it becomes an acceptance in science, and you can quote it. Talking about other discipline, I think I've answered that.
Yes.
Especially is once you now have when Tessier cases, neurosurgeons become central. Neurosurgeons become central. Neurosurgeons become central. That little girl I showed probably will have given us an opportunity of doing that. We were actually preparing for that. We already involved neurosurgeons in the management, but unfortunately, we lost the baby in the process of early management. We could not get to surgery stage. So probably, but basically, it should be known. Plastic surgeon definitely will be needed. Maxillofacial will be needed. Depending, ENT surgeon. You see, in centers where all these are available and we understand how to harness them, becomes very, very important, and patients are better for it. Okay. Do I still have somebody talking about some genetic?
Yes, genetic involvement.
Actually, it's a lot. I cannot say yes, I cannot say no, because I've not done anything in that respect. So it's not impossible, but as I said, I cannot say no, I cannot say yes. There's a possibility. The only thing is that at least by a paper that multiple authors that were presented from our patients from Nigeria in a number of African countries. A lot of genetic factors have been identified with cleft lip, cleft palate, but for atypical, I'm not sure.
Okay.
Yeah.
Okay. The last questions. There's the last batch of because of time. It says, how did you reconstruct the commissure of the Tessier 7? And somebody is requesting that you show your screen, you show your reference on screen. But I think that one, at the end of everything, Smart Train will send the presentations to us. So what I think you will get the full reference of whatever he used. So if you can take, I said, how did you construct the commissure of your Tessier 7? Do you involve plastic surgeons for your atypical cleft repair? That's another question. I think also I've asked your question. All right. I think that's it for the day. Yeah.
Okay. Thank you very much, Mr. Moderator. As I said, atypical facial cleft repair, the algorithm simply is anatomical. In the case where this is even bilateral, in a case where it's unilateral, you use the commissure on the other side as a guide. But in a situation where you don't have, then you are left with your imagination. Now, asking how did I do it? I do it because the mouth has always been my comfort zone, and I know what a commissure looks like. So, and if I want to restore an anatomy, from day one in medical school, I've been studying the mouth. So, what is important about the commissure repair, as in this case, is after the epithelialization, then you bring it together. It has to be mucosa for mucosa, muscle for muscle, and skin for skin. So that is it. Then regarding whether I involved a plastic surgeon or I did not involve a plastic surgeon. You see, as we continue in life, we will continue to appreciate interdisciplinary management of cases. Yes, if I'm in a place where I'll be too happy, and some of my colleagues and my friends around will tell you, I'm too happy to seek opinion and things like that. But you see, the way our system operates is not enough cases that you want to say, okay, I have a tertiary case. Just like the same way, the plastic surgeon has a tertiary case, you won't have to look for a maxillofacial to say, okay, you go out in the mouth, come and look at this. So the only thing is that it's very important. We appreciate multidisciplinary, and if you need assistance, if you are at the center, we should be friends of ourselves. There's no ego in management of patients. Let's be frank with ourselves. A patient that comes to the hospital does not know plastic surgeon. He doesn't know maxillofacial. He doesn't know an ENT surgeon. All the man knows or the woman knows is that he wants to be well. So if GOPD send the patient anywhere, that is their cup of tea. So it is for us to see patients at the center of our management, and so that they can benefit from our maximum knowledge. I think that is my take on that.
All right. Thank you very much, Dr. Bello, for such a wonderful presentation. We thank you so much for your time and everything. Just a little on the commissure repair. I think for measurement is also always very important. For lateral clefts, their facial columns are there for us to use as a point of reference to measure to the lateral side and measure to the lateral side on both sides to get a very good asymmetry. And always the vermilion, there's always a distinction between the normal vermilion and where the cleft ends and where the cleft starts from. And once you look at that, then you can use your anatomy of the muscles, the labia muscles and all that to also close. So that's just a little indication I want to add to what Dr. Bello have said. Somebody is also saying that a guide from the popular level, mid-popular level to the commercial is also another guide that you can use to get to the commercial, where you have to end your commercial. So thank you very much, Dr. Bello, for such a wonderful presentation. And thanks to everybody for coming to this platform. Thank you for all the questions and the contributions. We also want to use this opportunity to say thank you to SMILE Train and the West African College of Surgeons for putting this together for us, as we keep on sharing ideas and skills, all for quality care for our patients. Thank you very much. So now I will hand over to Esther to tell us what we have next week. Thank you very much.
Thank you, Dr. Obiri. Thank you very much, Dr. Bello. That concludes our lecture today. And next week, we see you same time, same link, and invite more of your friends. Have a wonderful week.